Dr. Anurag Mishra. So I think prolific surgeon beyond the rings in presbyopia correction. All to you, Anurag.
Thank you, sir. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. Now, when we talk about ring designs on the IOL, essentially we are talking about trifocals. And why do we look beyond the rings? This is a concept which has come very recently. Why do we have to look beyond the rings is because the ring design essentially causes this. You've got three foci of objects which produce three foci of images on the other side of the lens, starting from the nodal point. And when you are looking at one particular object, that particular focus becomes more prominent than the other two. So we have three foci, one for distance, one for intermediate, one for near. And when you're looking at a near object, for example, the other two foci become relatively blurred, but they're still existent. So three distinct foci will give you crisp vision for three different distances, but all the three foci will be active all the time, irrespective of where you look at. That was actually the reason for which the concept of EDOF, or extended depth of focus, came in, which essentially turns the focus into a line. Now, according to the definition of US FDA for EDOF, you have to have the focus in the form of a line, and it has to offer a defocus of minimum 1.5 diopters for that lens to be categorized as an EDOF. Right. So to combat that, the ring design, there were two things that came in. One is obviously the monovision, wherein you put in monofocals in both eyes and render one of the eyes myopic so that it gains near vision. The other was a fusion or paired approach. The first paired approach came from a company called Acritech, and the lenses were called Acritwin. Interestingly, they had brought out lenses both in single piece and multi-piece designs. Both of these were multifocal IOLs. However, the design differed in the sense that they had 70-30 ratio. One was 70% dominant for distance and the other was 30% dominant for distance. So both the eyes getting both the IOLs will get multiple foci. However, one eye has a distant dominance and the other has a near dominance. The other paired approach that is there in the market is the Geometric and the Geometric Plus coming in from Hoya. Excellent IOLs. I think Anurag is going to speak on it later on. But they have a variation in the step height, which differentially distributes the light according to three different distances. The combined platform that I'm going to speak on is actually called the Well Fusion technology, which has recently been launched from the house of SIFI, coming in from Europe. This particular paired approach is based on EDOF IOLs on both eyes. So both of these IOLs are EDOF IOLs, but how they play around with this is with the means of spherical aberration added or subtracted. Now these lenses are called the Mini Well and the Mini Well Proxa, both of the IOLs. Let's talk about the Mini Well first. The Mini Well has three zones, as you can see here. One is shaded green, which is near dominant. The other is a peripheral girdle of red, which is spherical aberration subtracted from the central zone. The central zone's 2 millimeters in diameter. The peripheral girdle, the immediate peripheral girdle is 1 millimeter, where they have added on negative spherical aberration, and then the broad peripheral zone of 3 millimeters, which again has positive spherical aberration added. So what it means is the central zone is near dominant, the red zone accounts for intermediate, and then the peripheral zone is dedicated towards distance. Now the Proxa, on the other hand, has 5 zones. The central disc is for distance, so distance dominant. Then there are 2 zones, and there are 4 zones alternately dedicated for intermediate and then for near. So the difference between the two platforms is the optical zone, the active optical zone with the Mini-Well is 3 millimeters. It's 5, the zones are 3 in Mini-Well, the zones are 5 in Proxa. The active central area is 3 millimeters. With the Mini-Well, it's 4.5 millimeters in Proxa. And then the focus lies at 40 to 45 in Mini-Well, which brings in further closer to 30 to 35 with the Proxa. So again, I would like to emphasize on the fact that both of these are EDOFs, both of these are line foci, but the focal distance it offers clear vision at is 30 to 35 in case of Proxa and 40 to 45 in case of Mini-Well. So what essentially it does is effectively, it gives us the, oops, sorry. Somehow it's getting stuck in here. Okay. So it's essentially giving us the add power from 1.5 to 3.5 millimeters. Again, both of them being designed on the EDOF platform, none of them having any rings in their design factor. Talking about the material, it's a copolymer, so it's not a pure hydrophilic, it's a hydrophilic and hydrophobic combined, high refractive index. It does get in 2.2 millimeter incisions. However, there is a slight amount of blinker in that. I'll just speak about it in a minute. It has a double square edge and is preloaded, which keeps us away from the contamination principles. The only case wherein I would, of course, when you have designs like these, you're not really concerned about the alphas and the kappas because you have a central 2 millimeter zone. And I've hardly seen anybody's alpha going beyond 1 millimeter. So it's actually not a concern. What is a concern though, since you're playing around with aberrations, both spherical, positive and negative, the MTF curve drawn from the cornea preoperatively is something I always look at before I give any IOL that plays around with a spherical aberration. Look at this patient, for example, and the cutoff mark for me is a 0.4's value at 10 cycles per degree. If the value drawn from the cornea is beyond 0.4 at 10 cycles per degree, that patient is a suitable candidate. Because the MTF drawn from the internal plane, which is a cataractous lens, will always be low. We know that. But the corneal MTF, the corneal contrast should be good. This patient, in contrast to the earlier patient, which has a low contrast sensitivity already, the MTF is bisecting this critical square, will be designated as an unsuitable patient to me to receive any IOL that plays around with spherical aberration to impart depth of focus. The other blinker, as I said, since it has a tetraport haptic design and the haptics are a little broad when they fuse with the optic at the time of implantation, they at times just topple over, they flip over because there's a resistance coming in from the CCC margin. So if they topple, there's nothing to worry because the overall diameter is not much. It's 11 to 11.25 millimeters. So with the same irrigation cannula, I can just go in and with the second instrument can flip it over before guiding it into the bag and keeping it there. So nothing much to talk about in the implantation technology. It's quite smooth. The material's good. And I don't have loads of experience to share with you with regards to how the patients behave post-operatively, but whatever limited experience I've had thus far, it's behaving pretty well in my hands. The only thing that is a concern at the moment is the proxa, which goes into the non-dominant eye according to my principles, does not have a toric trim at the moment. So I just hope they bring it out soon to the market. Thank you so much for your attention. Only if both of the eyes allow that principle to be operational. Sometimes they don't. Then the mini well goes in both eyes.
Dr. Anurag, interesting presentation and very interesting concept. So I was just wondering, the proxa, which has more zones, 5 zones as you said, probably may have a lower contrast compared to the mini well.
Yeah, that's the reason why.
Yeah.
It's not about proxa, it's not about mini well, it's also true about VVT, it's also true about any IOL that is basically working on the EDOF platform. The VVT, of course, doesn't play around with the spherical aberration, so it's a safe IOL to be put, even if the contrast is low to start with. But any IOL that has even a minimal amount of spherical aberration added, we should look at the preoperative contrast sensitivity coming in from the cornea. If it's low, it should not go in because it's going to reduce the contrast even further post-operatively. So you're right, yeah.
So before we take on Dr. Gaurav Mishra, and he'll be talking on beyond distance with advanced monofocal IOL, just a quick question from you, Anurag. For the minival proxa, do you feel the dysphotoptic symptoms a little more as compared to the minival?
Yeah, so the paucity of time actually prevented me. But the other thing that I should always look at, I would always look at, particularly when it comes to the proxa eye, is the preoperative pupil and the preoperative mesopic pupil in particular. So if the preoperative mesopic pupil is more and it's large, then I would stay away from it because, as you rightly mentioned, sir, it has more zones and the dysphotopsia is likely to be high if the pupil size is high. But if the pupil size is somewhere around 3 to 3.25 millimeters preoperatively, and we always look at the pupillary size both under mesopic and photopic conditions, then there's no issue. But what you're saying is right. Dysphotopsia is bound to be a little more as compared to the mini-well eye and to the other IOLs as well.
So in your experience, those hypercritical patients who are driving and, you know, young, are they candidates, and what has been your experience
No,
with that?
that in itself, by itself, as a standalone is not a contraindication, because the photic phenomenon that arise from these IOLs is not as bad as you would have them from a full optic multifocal IOL, because they don't have steps. So the step dysphotopsia is always more. That's always more distressing and disturbing. This is not as bad as that, but still. So driving is not a contraindication, but if the pupillary size is large, I'll just be on my caution.